All right, so we're doing sepsis today, and it is going to be a lot of things. I know you just took your exams, so you're not going to feel too great. So that's how you feel right now. It's okay. All right, you know, won't retain much of this, but it will be recorded. All right. So sepsis. So we'll be focused on a few different disease processes, especially like MDROs. So MDROs are multi-drug resistant organisms. Those are important because they're life-altering and they are very deadly. What's an example of an MDRO that you know about? VRE, MRSA, C. diff, all right, Acinetobacter if you're fancy. All right, so all these are MDROs that are deadly. All right, so we have to recognize those. We know the treatments for those. And then we're going to be very generic. We've learned a lot of infectious diseases up to now, like you've learned about UTIs in Med-Surg 1, and also in women's. You learn about pneumonia here and there. So we'll be talking about all kinds of, and we talked about ascending cholangitis. We talked about cholecystitis. We talked about different, GI infections. So we're going to kind of include a lot of those, and we'll include some more. Okay, so you have to know like what are the diagnostic tests that we have to do for this disease process, because sepsis is really, you're doing everything. You're looking through the whole patient and seeing, are they confused? Do they have meningitis, which is usually your last suspicion, but are they having breathing problems? Well, that might be a pneumonia. Are they having pain with urination? That might be a UTI. Do they have right upper quadrant pain, right lower quadrant pain, left lower quadrant pain? These are all things you have to survey. Okay, so that's sepsis includes all these things. And then next semester or next Med-Surg 3, you learn about septic shock. So we'll be touching a little bit on that, which is when sepsis progresses all the way to an acute resuscitation event. We have to resuscitate them and start vasopressors, do all kinds of fancy stuff. Right now, you're just going to be introduced that is a complication, right? But you have to know all the other things that go into it. Okay, so sepsis. So sepsis is a bacteria. It could be, well, purple and blue doesn't look too good. All right, so you got a bacteria that makes its way into the bloodstream. All right, it's what's called septicemia, means emia meaning it's in the bloodstream. All right, but sepsis can result from an infectious source somewhere, and that's usually our goal, is to find where that source is, take it out if you can. Otherwise, give them antibiotics, all right? And antibiotics within 1 hour is what we want, all right? You can see it costs about $24 billion per year for sepsis. Well, I did draw a circle 5 seconds ago. Okay, so yeah, $24 billion is how much it costs just to get per year. For sepsis, this is like 2016, 2018 or so. Mortality rate up to 50%. That's just with sepsis. If you have septic shock and you go into another complication, multi-organ failure, that can lead to up to 100% mortality, right? And there's not many disease processes that are like that where you die 100% of the time, right? Even cardiac arrest has better outcomes, right? If you go cardiac arrest and you need CPR, every minute of delay is about a 10% chance of dying, right? So if it's a 7 minutes of no CPR or actually with CPR, then you're going to get better outcomes, right? But sepsis is much more deadly, okay? So different things I teach the patients and families is, time is an acronym you teach them. All right, do they have a temperature elevation? Is there something obviously infected, purulent, right? And it has they have a tenderness to a joint, tenderness to an area of their body. It might be infectious, so we have to make sure that the families and patients are aware of it, because I think there's a stat on here about a lot of people know, was it 72% of Americans identify stroke symptoms, right? What are stroke symptoms? So be fast, right? So we got a good campaign on that, but less than 1% can identify sepsis symptoms. Like, do you have sepsis or not? I don't know, right? So you have to be able to teach to this, right? And the M is mental decline. Are they altered? Are they not like themselves, right? It might be a stroke, but usually strokes have focal deficits. Like, I can't move my right arm, I can't speak, I peed myself. These are focal deficits, right? Whereas sepsis is a generic encephalopathy, a generic decline in mental status, right? And then E is extremely ill. They look sick, right? They look like they're pale, like death warmed over, right? That is a septic patient that you can teach to someone. Okay, so what is it? Antibiotic administration, just like we talked about CPR, every minute counts, every hour counts for antibiotics. So if you wait, every hour you wait, you're gonna, or was this, you improve it? You improve their Likelihood of death, yeah, increases every hour you wait to give antibiotics. So you give it at hour 3 versus hour 1, it's better to give it earlier, right? So we have things we want to do within the first hour, right? We want to get antibiotics going, but before antibiotics, you usually want to give what? You want to get what achieved? You want to get cultures done, so we know what sepsis, what bacteria is growing there, right? And that's the big thing, is we give antibiotics empirically. Empirically meaning that we give it to cover most things, right? So 1 in 3 patients will suffer sepsis, and it has a very, very high readmission rate. So I think I knew this, but then I didn't know it when I had to write a response about it recently. That you think like CHF, you're always get a CHF patient in the hospital. You get a COPD patient, they're always getting readmitted. Sepsis is like almost double that for readmission rates. All right, so if you got a patient that has sepsis, they're going to be bounced back within 30 days, about 42% of the time, or something ridiculous. Okay, so here's something for you if this makes sense to you as far as mnemonics, as far as like symptoms, but we'll go over the symptoms as well. And usually the symptoms relate to the area of the body that's infected, right? Again, if they can't breathe and you got an x-ray that shows infiltrates and shows patchy cotton balls all over the lungs, they probably have a pneumonia. And that's probably what's causing their sepsis, right? So overview and inflammation. So sepsis is a life-threatening infection. It can get into the bloodstream, and then that's going to cause a widespread inflammation, right? Because you're basically, that has gotten to the bloodstream, or it's caused a widespread response that is inappropriate, right? So we have inflammation, which is great, right? So inflammation is when you stub your toe and it inflames, right? So when that inflames, that's great. That's going to target where the white blood cells have to go. It's going to send off, we're going to send off a whole bunch of signals from our little white blood cells that are kind of patrolling nearby. They're going to send off a whole bunch of signals, and they're going to cause the swelling and leaking of these vessels, so that those things can easily get through. It makes them super leaky, and now that area gets puffy, and it makes it difficult for bacteria now to swim from point A to point B. Now they only have to swim. They have to swim much farther when we swell it up, right? And also that makes it more leaky, so the white blood cells can get out. We actually thrombose at both sides, so if the bacteria do get through into the blood vessels, we can thrombose and throw a little clot over there, and that clot's going to prevent the bacteria from going away, right? So that's great if you stub your toe or if you cut your toe and it's something nasty you cut it on, right? So that's nice, but if you have this bacteria is a huge infiltration into your bloodstream or infiltration nearby, that's going to cause a widespread inflammation. Okay, so it's a dysregulated, out of control host response, right? An overwhelming immune response to a severe infection. Okay, so that's going to cause all these little mediators that we mentioned before, all these little chemicals that get released here, right? It's going to, instead of just being localized, it's going to be everywhere, right? These are examples of those mediators, right? So these mediators are chemotaxins, cytokines. You may have heard of cytokine storm with COVID, right? So you have cytokines get released, chemotaxin gets released, prostaglandins, histamines, all these little things get released, and these things are going to cause a widespread inflammation through the whole body instead of just in one little spot, right? So we talked about SIRS before, right? So SIRS was it says an unstable internet connection. So SIRS before was was a systemic inflammatory response, which can be due to infection, or it can be on its own. Like we talked about on the exam this morning, what's something that has a SIRS response? That's a widespread insult to your body. That's pancreatitis right here, right? So pancreatitis has a SIRS response, right? With an infection, you also have a SIRS response, right? I don't like how delayed it is. Anyways, we have SIRS. You can have SIRS independently. So if you get into a massive trauma, you can have a SIRS response. You have a massive burn, right? That could cause a SIRS response, but also infection can do it. Usually infection is more common. Like we have a bacterial infection, obviously a lot more common than a parasitic infection, but these are things that can develop and when you have a an insult to the body, whether it be a physical insult like pancreatitis or trauma or burns, or be an infectious insult like bacteria most commonly. Viruses can do it too, right? That's why we tell older people to get their influenza shot so they don't get hospitalized for this widespread inflammation from the flu, right? So very high mortality. It can be up to 100% if you have multi-organ failure involved, right? But it usually is up to like 50%, depending on other comorbidities, all right? If you're older, you have a disease severity, I mean, like how bad the sepsis is, use of chemotherapy, other devices in use. What's a eclampsia and CAUTI? So central line associated bloodstream infection, right? And a catheter associated UTI, urinary tract infection. So, and what's a VAP? That's a ventilator associated pneumonia. So basically this is plastic that's causing infection, right? So our goal every day in the hospital is to take plastic out of the patient if they don't need it, right? So take them off the ventilator, take the central line out, take the catheter out if you can. Okay, so again, the normal immune response, the local macrophages, the monocytes and such, they spill all their beans. They spill all those chemicals right here. So we got, tumor necrosis factor, interleukin-4, interleukin-13. As we learn about hematology, is that next week or week after? When we learn about hematology, they're not creative hematologists in how they name things. Like you've heard the coag cascade, right? Yeah, they name it in Roman numerals, right? Those guys don't have your back at all. All right, so they have like interleukin 1 through 44, and they have all kinds of other little chemicals out there that get released, and it causes a widespread inflammation. It also attracts things. Chemotaxins are things that are like taxis, like they attract things to the area, right? But when it's in the bloodstream, it's just like, where is it supposed to go, right? So everything, all these inflammatory mediators get through the whole bloodstream, and they do what they would do on the big toe everywhere, right? So they make everywhere leaky. They make everywhere vasodilated, right? So this vessel dilates down here as well. Everywhere they make clots, right? And when you make a clot, what do you use to make a clot? What do you need to make a clot? You need the mesh, right, which is your fibrin, right? And you need the actual coag cascade, all the clotting factors, and eventually you need fibrin. Sorry, so you need platelets. Sorry, I was backing up. So your whole coag cascade makes the fibrin, right? All those different steps all coming down to 10A, to thrombin, to fibrinogen, to fibrin, right? And then we have the other piece of a clot, which is what? Platelets, right? So then you can consume all your platelets with widespread clotting, right? That's called a disseminated intravascular coagulopathy, right? You have coagulopathy because you're clotting everywhere. You're using all your platelets, so they are bleeding a lot. That's one of our complications of sepsis. Okay, so we talked about complement activation, all these cytokines and everything, all these different chemical mediators go through the whole body, right? And then we have the coag system mentioned, right, is going to get activated. And then this inflammatory response is everywhere, right? That redness, warmth, pain, edema is now everywhere, all right? So in Latin, it's rubor, dolor, tumor, color, right? All those things are going haywire, all right? So we have widespread swelling, widespread vasodilation, widespread inflammatory response. And we are going to try to turn it off, right? But that's the anti-inflammatory mediators. So we have inflammatory ones and anti-inflammatory ones. The anti-inflammatory ones obviously are good, right? And we give medications that potentiate the inflammatory mediators. What are those things? What's a medication that's anti-inflammatory? Steroids, right? So steroids can be given in sepsis to help support the patient, right? And the inflammatory mediators, those guys are going to be causing a lot of damage. And the reason why they came out in the first place was because of these PAMPs and DAMPs. I lost connection. How you doing? 1 second, Zoom is connecting. You have to go up front.
Was that the first slide?
This is our third slide.
Was it still sepsis?
Sepsis, yes.
Recording in progress.
So apologies for the Wi-Fi. 1 second. All right, let's see if that works now. There we go, slowly. All right, anyways, you have all these inflammatory mediators that get released, right? And what triggered it was something called PAMPs and DAMPs. We got pathogenic mediators, right? And we have damage associated. So yeah, pathogenic and damage associated, meaning that we have our own immune system play it ourselves, right? So congratulations, we are playing ourselves. All these inflammatory mediators are flying through the whole body. They're causing widespread inflammation. It could be our own self that's causing inflammation, but also it can be the pathogen itself causing that immune response, right? So all these things are leading to sepsis, and that leads to the cytokine storm we talked about. All these inflammation going all the way through the body until we have organ failure. Because as we'll learn in the next slide, this not only does the inflammation cause problems in vasodilation and low blood pressure and widespread leakiness of our vessels, but it's also going to cause our organs to shut down. Okay. All right. So what happens with sepsis again? Sorry for the delay. There we go. All right, so it's an amplified and out of control immune response, right? Out of control inflammation, right? And that can lead to complications, right? This complication we mentioned were clotting, right? So we are losing all of our clotting factors, all of our platelets can get consumed by this widespread clot, right? Throughout the whole body. And that leads to what's called DIC, which we'll talk about later, right? But DIC is disseminated intravascular coagulopathy. And the other piece that happens is that we have this widespread inflammation, and we have the anti-inflammation, the anti-inflammatory mediators, which are helpful, and we want to be able to help out the body. But these guys can't catch up because, first of all, you have this widespread inflammation, but then also you have this sepsis also brewing, or this bacteria or this pathogen that's also brewing, also causing the widespread inflammation in of itself. So we really just can't catch up, right? It's hard for our body to fight that. So what we can do is give antibiotics to fight off the infection so that our anti-inflammatory piece can recover, right? So what can happen eventually is this widespread inflammation can start causing vasodilation, as we mentioned, right? It leads to what's called septic shock, right? A shock state is where you have poor perfusion, and eventually it can lead to low blood pressure, right? So you got a MAP less than 65. All right, so MAP less than 65 is usually a good target for most organs, right? Especially the kidneys, because the kidneys will get upset if they don't get their blood pressure, all right? And we got this a lot of pro-inflammation compared to anti-inflammation. That's our DAMPs that we talked about, and the gram-negative actual cell wall of bacteria. So we're going to across the way there. We got the microbiology lab. So if we need some tune-up at the break, about gram-negatives, gram-positives, anaerobes, mycobacterium, all that stuff, I'm sure they'll fill you in as well. And we will fill you in as well today when we talk about antibiotics, because those get complicated when you talk about which antibiotics for which. Like this antibiotic does gram-negative, this antibiotic does gram-positive. So what does that mean, right? Which bacteria are gram-positive, which bacteria are gram-negative, right? But gram-negative, they are toxic. Gram-positive are toxic as well. They release toxins, right, technically. And that's going to cause a widespread inflammation in of itself. So you got inflammation and inflammation, right, from the body and also from the pathogen that might be causing more and more damage, right? So you got poor perfusion to your organs. Your organs are going to start shutting down. So that's bad, right? Your organ shuts down, but also the sepsis process itself, the inflammation process itself, causes the mitochondria to shut down, right? And what are the mitochondria for? Powerhouse of the cell, of course, right? It makes ATP, right? And if you don't have oxygen to your cells, you don't have the mitochondria aren't working, then you start going to what's called lactic acidosis, right? So lactic acidosis is anaerobic without oxygen, and you get all this lactate buildup, right? So one of the things we measure in sepsis is lactate, right? Lactic acid levels. And lactic acid levels, if they are 10, that's bad compared to 2, right? So if you have lactic of 10, they have really, really bad sepsis. Lactic acid 2, not so bad, right? And also they could get better or they could get worse. We can trend those lactates to see where they're going. Okay, so you got more inflammation, further organ damage, and then the mitochondria start shutting down. So it wasn't only just the insult of vasodilation through the whole body, it was also the inflammatory process and the pathogens that are cause the mitochondria to shut down, right? So you can have the best perfusion, MAPA 70, MAPA 80, but you still have widespread sepsis, and that's going to cause your organs to shut down, especially if you're a higher risk, right? So lactate we can measure, right? Lactate goes up, pH goes down. If you remember back to Med-Surg 1 and pH, what happens when your pH starts going down? Your vessels can't maintain their contractility, and they vasodilate. So now you got twofold. You got vasodilation from the inflammatory mediators, vasodilation because your mitochondria don't work, and vasodilation because you have lactate buildup. So it can quickly progress to a widespread vasodilation, widespread poor perfusion, which means a shock state, a septic shock state. And now, obviously, multiple organs can now start shutting down, right? And they weren't, it wasn't designed by hematologists. It's called multi-organ dysfunction syndrome, which is nice, right? It makes sense. Multi-organs shut down because of widespread poor perfusion from a sepsis process, all right? So multiple organs can shut down. So here's an overview. We got a bacteria in our bloodstream. It's getting through. It's causing all kinds of release of these inflammatory mediators, and that's going to then trigger our immune response right here. I'll circle in green. That's supposed to be green. All right. So immune response flies off, and we have this widespread inflammation, and then we realize that we played ourselves, that we overdid it, right? Overshot it, and we try to increase the anti-inflammatory parts, but we just can't catch up, right? So we have to A, mitigate ourselves, and B, get rid of the offending source, right? So if it's pancreatitis that's causing a widespread inflammation, we got to fix the pancreatitis. If it's a burn state, those are more harder to fix, but we can fix sepsis. If you turn the patient over and you see a huge abscess, right, that might be causing the sepsis. Or you turn the patient over and you see a stage 4 with osteomyelitis, that might be the source of the infection, right? They have breathing difficulty, it could be pneumonia. They have urinary difficulty, it could be UTI. They got abdominal pain somewhere, it could be abdominal. They got a knee that is hot and inflamed, it could be septic arthritis, right? So all these things you have to survey to see if there's something wrong, right? This could be causing them to have symptoms of sepsis. We talk about hypotension being one and also lactate being one, but we're going to kind of put it on a spectrum, right? It goes from a early stage to a late stage. The latest stage, of course, being multi-organ dysfunction syndrome. That's not good, right? The earliest stage just being sepsis. Okay. So again, the bacteria gets in, causes our brain to shut down, mitochondria in our brain. It's not unique just to one area of the body. It's everywhere, all right? So we start getting altered, right? Especially who gets altered when they get infections? Elderly get right? So we have all this inflammation going through the whole body, causing all kinds of damage, right? So over here also got a vascular instability. We got microvascular occlusions. Why are our vessels getting occluded? I thought they were just vasodilated. It's because the widespread clotting through the whole body as well, right? So not only were the mitochondria being shut down and the vasodilation reducing perfusion, but also we're forming little clots to our organs so they can't get perfused in the first place. Even if you fix the lactate, you fix the vasodilation, you still have little clots going to your organs, and the organs start shutting down for that reason as well. Okay, so sepsis and multi-organ failure. So vasodilation equals what vital sign change? Equals hypotension, right? When you get hypotensive, the SNS fires off, and what do you get? You get tachycardic, they get tachypnic, probably diaphoretic, right? And then capillary leak, they might get a little bit swollen, but really the fever is a sign of an inflammatory response, right? All those different little chemotaxis and interleukins and cytokine response, one of them is interleukin 1, and that one triggers a fever, right? Tylenol blocks interleukin 1. So that's, you could get Tylenol, but they have something bigger cooking, right? And then coagulopathy. So how do you measure coagulopathy? How do you measure if someone's platelets are being consumed? You can look at the CBC and look at the platelet count, right? Also, you can look at the coag study to look for coagulopathies, right? So what kind of coagulopathy studies would you look at? You get PTT, right, and INR, right? If those are prolonged, that means it could be a septic process, right? Now again, on the test, we're not going to confuse you. So you got a cirrhotic patient and they're septic, right? So because yes, a cirrhotic patient can also have their own problems, right? There's like a clean slate almost. All right, so the sepsis spectrum. All right, so we talked about sepsis, but there's one step below sepsis. Well, it's not really below, it's just concurrent with. You could either be SIRS or you could be sepsis. The only difference between SIRS and sepsis is what? An infection, right? If you have an infection present, congratulations, you started at sepsis. If you can't identify the infection yet, you are SIRS. And you say, oh shoot, they just got in a huge motor vehicle accident and crushed half their body. That is the SIRS response, right? That wasn't an infection, that was the SIRS response, right? They have acute pancreatitis. And acute pancreatitis is going to cause a widespread autodigestion of the abdomen and cause widespread inflammation, right? So the symptoms here should make sense, right? We have a widespread inflammation. Remember, a fever and an inflammation it triggers the SNS as well. So SNS fires off, we're going to get a heart rate that's elevated, a respiratory rate that's elevated, and of course we get the inflammation, which is the temp going up. Sometimes some patients will get a lower temp, right? They can't really mount a fever, like an older patient, right? And then white count will go up, right? So that's a sign of inflammation and a sign of an inflammatory response, okay? And so elderly may not even have fever, as we mentioned, right? And just to note that the white blood cells can be high or low, just like the temperature can be high or low. Not the heart rate or the respiratory rate. Those ones are definitely going to be high, okay? So that's SIRS. The only difference between SIRS and sepsis, again, is what? Source of infection. So it's just SIRS with a source of infection. How do I know I have an infection? I had an X-ray, I had a UA, I had a CT abdomen that showed a perforated diverticulum, right? That is a sign of infection, right? So those are septic. So those are that's the only difference between SIRS and sepsis. All right. There is a little difference between early and late sepsis. So like early, your body can try to compensate, but eventually it fails, right? It's usually the sepsis will get a hold of them, and they will exhaust their SNS response. They'll exhaust all the resources, and they will then get cold, all right, cold and clammy. But at first, they might feel warm to the touch. They might feel a little bit like what's called hyperdynamic, where their heart rate's like really beating really fast. But eventually, they will peter out. Right, so then now we're just on the same pathway. SIRS can go almost the same pathway. It can still have organ dysfunction. It can still have widespread hypotension, but usually we use the sepsis highway as a guide. Right, so we started at SIRS or sepsis. Right down here, SIRS or sepsis, and now we're going up to, and we're going left to right down here. Okay, so we're going from sepsis to severe sepsis. Right, so we have all the signs of sepsis, which are what? Source of infection plus SIRS. And what's SIRS? You've got a white cell count, you got a fever, you have a tachycardia, and a tachypnea, right? So it's just those four things. Because you could be diaphoretic with an SNS response, you could have pupils being dilated, right? You could have those other symptoms, but these are the four objective things. You can measure it easily, right? You can't really measure someone's diaphoresis. Yeah, it was like a 3. Shoot. You can't really measure diaphoresis, but you can measure someone's heart rate, you can measure someone's respiratory rate, you can measure a temperature, you can measure a white count, right? And I didn't point out, but it's only 2 of these, right? So you just have to have 2, right, for you to have SIRS. So if you have 3 of them, more power to you. But if you have 1 of them, you don't have SIRS yet. You still need something else to define it. Okay? So severe sepsis is all the signs there. Now we're just going to add on to it. All right, so severe sepsis, you can imagine, we've mentioned first you mount this inflammatory response, but next it's going to start causing organ dysfunction, right? And all these things are signs of organ dysfunction, right? We've got a blood pressure that might be low, we got a T-billy that's going high, we got a creatinine that's going up. What's creatinine measuring? Kidney function, the kidneys are shutting down, the platelets are going down, that's a hematological dysfunction, right? It could be liver damage, you could argue, but really you're just using all your platelets, right? The lactate's going up. What's lactate mean again? That means we have poor organ dysfunction, right? Where our organs are shutting down. They've gone from an oxygen state to an anaerobic state, from an aerobic to an anaerobic state, right? So all those things are shutting down, and we can measure that, right? How many do you need? One of the following, all right? So just need one of those things, and congratulations, you have severe sepsis. So severe sepsis is 2 SIRS plus 1 organ dysfunction. Okay, and it's these ones, right? This is very, very well delineated, right? Medicare, insurance companies, they all want to have exactly know where they're at, make sure we're not overbilling or underbilling, right? So it's these things, right? They have a low blood pressure, they have signs of organ dysfunction, okay? And with blood pressure, there's a little caveat in blood pressure. Yes, it's a systolic less than 90 or a MAP less than 65, but also it's a 40-point drop from baseline, right? If someone comes in, they're on 3 antihypertensives at home, and then the blood pressure is 96/40, so they're perfect. It's like, no, they probably, and they haven't taken the blood pressure meds, they probably are hypotensive. So it's a 40-point dip from baseline also, just a caveat there. Okay, and then septic shock. So that's where you've gone, you have everything that we just talked about, plus you have what? You have persistent symptoms. Your blood pressure does not elevate, right? You are having a lactate that's actually greater than 4. Right, where are we at here? Lactate greater than 4. So you can actually skip steps. So if you hold lactate and it's like 6, it's like, oh, they only have severe sepsis. But no, if it's greater than 4, you already gone all the way over to septic shock, right? Remember, a shock state is just poor perfusion to the body, to the organs. So we have poor perfusion, which can be obviously your organs are failing in severe sepsis, but if they are really starting to fail and you're into a shock state, you're going to have persistent low blood pressure, right? So the blood pressure is really low, right? And it's sustained low. We have to support them. We have to support their blood pressure. How do you fix someone's blood pressure? You can give fluids, and what else can you do? You can give vasopressors, right? And pressors, you're going to talk about in Med-Surg 3, right? That's where you talk about vasopressors and septic shock. You talk a lot more about how to fix that shock and other shocks, right? But you have to know right now that sepsis, one of the complications can be septic shock, right? And of course, septic shock, another complication of sepsis. Yes, it's septic shock, but if that persists, then what happens next? You get multi-organ dysfunction, right? And MODS, okay? Multi-organ dysfunction syndrome, okay? DIC can be thrown there anywhere along the pathway, but eventually multiple organs shut down, and then it leads to death, right? The mortality can go all the way up to 100%, depending on how many organs have shut down, okay? So multi-organ dysfunction syndrome. That's where you have 2 or more organs that have failed, right? So your kidneys have failed. How do you know your kidneys have failed? The creatinine's going up. What else? Electrolytes, and they probably aren't peeing, right? So urine output is poor. How do you know your lungs have failed? Yeah, you're not breathing, or you're on a ventilator, right? So you're on a ventilator in the ICU. How do you know your brain has failed? You're altered, right? Your GCS is poor, right? And how do you know what else? How do you know your heart has failed? You can look for troponin levels. You can also look for, we can actually do other fancier things that you learn in Med-Surg 3. You can actually measure the pressures in the heart, and they're failing, right? Like you have CHF, all the blood backs up into your lungs, and the pressure in the lungs will be higher, and the pressure outside the lungs and the systemic circulation will be lower. We can measure that. So these are all called what's called the SOFA score. You don't have to know the SOFA score for the test. This is just a way to illustrate that when the numbers start going from 0, which is stable, all the way to 4, that equals like our cardiovascular system has shut down, our CNS has shut down. We look at the GCS, our kidneys have shut down, right? Our liver, our coag system, our hematological system has failed, right? Or our respiratory system is shut down, right? As we get higher and higher up on that scale, in each one of those categories, you assign a number to it, you can get their risk of dying, their mortality score, right? It's not something you have to calculate, it's just to illustrate that organs start shutting down, and the more organs that shut down, the worse off you are. And how many organs have to fail for you to have MODS? You just have 2 organ fails, right? It's 1 for severe sepsis, but when you start assessing organs starting to fail, you're pretty much in a multi-organ failure. So just 1 organ fails, severe sepsis. 2 organs fail, MODS, right? So we got a pathogen here, right? We got other things that could happen, but we got a pathogen, invades the host, right? Causes a widespread inflammatory response of our own, right? Our anti-inflammatory response will try to fix it, but that inflammatory response will cause problems, but also the pathogen itself will cause problems, right? And that will lead to ultimately organ dysfunction, and we have all these organs that can fail, right? And we can assess that, right? We can assess if someone's organs have failed. We can assess diagnostic tests to see if they are working or not, right? If the organs are working or not. So when someone comes in with sepsis, you have to do all the things, right? You have to look at head-to-toe assessment. You have to do all the diagnostic tests, and you're going to do what's called pan culturing, right? So pan culturing means not just culture one thing, but culture many things. So you're going to culture the urine. What else can you culture? You can culture stool. It's not very, very common if someone comes with sepsis, but sputum, right? So you can culture the sputum, culture what did we say already? Urine. What else can you culture? Blood. You do blood cultures, and what else? Wound cultures, right? So they got a really, really gnarly wound. You can do that. Even if it's not like a decubitus, but it's pouring out, purulent material. Right, you could culture that to see if that's causing their current infection.